Hello, everyone, and welcome to this free webinar presented by WePast. My name is Christina Ruiz, and I will be your moderator today. Throughout the webinar, we will stop the presentation to review. There will be multiple choice review questions, which you will be able to answer in the polls section. Please go ahead and respond to these questions as they come up. You'll have less than a minute to answer each one. During the webinar, please feel free to use the chat to ask questions and discuss the topic. We will take time after the presentation to answer these. This and other recorded webinars will be available to WePast subscribers. You can register through wepast.com to become a subscriber. Today's topic is the use of surface imaging in radiation oncology, presented by Dr. Laura Padilla, Assistant Professor at the Department of Radiation Oncology at the Virginia Commonwealth University. Thanks for joining us, Laura.
Thank you for inviting me to speak about surface imaging today. So let's get started. First, I wanted to share with you what the goals of this presentation are. So hopefully by the end of this talk, you should be able to explain what surface imaging is, give a general overview of how current clinical systems work, state its two general uses in radiation oncology, and then summarize its current clinical applications, as well as be able to describe its limitations. The way that I plan to achieve this is by first giving you an overview of what surface imaging is and how it works. Then we'll go into what the current clinical systems are and present a couple of differences between the commercially available ones. We'll go on to discuss general clinical uses of surface imaging, and then I will present a couple specific applications that are very common nowadays in radiation oncology. And then we'll finalize the talk by going into some of the limitations and summarizing what we've reviewed today. So what is SGRT? This seemed like an appropriate place to start. SGRT is a term that's being used nowadays, and it is a very recent term, and it indicates the use of surface imaging in radiation therapy. It stands for surface-guided radiation therapy. And what does it really mean when you use surface imaging in the context of radiation oncology? We will go more into the details of that in a little bit, but essentially what you're doing when you're delivering a radiation plan is you want to make sure that the patient is in the exact position that you simulated them in, because that is the anatomy and the position of the patient that you use for treatment planning. So you want to ensure that that position is maintained throughout the whole treatment delivery. So surface imaging is a technology that allows you to do just that. So it evaluates the patient position in real time without the use of markers or ionizing radiation. So it kind of frees up the therapist a little bit. It takes the pressure off of them. They don't have to constantly be watching the patient. They have a backup system that notifies them when the patient moves. And if you have it integrated with your treatment machine, it can also stop the beam automatically. So what's good about surface-guided radiation therapy is that essentially you have a system that is constantly watching your patient, even if you are not. This tool can be used for both initial positioning of the patient and for intrafraction motion detection, obviously. And because it can be used for intrafraction motion detection, you can also use it for respiratory motion management, which we'll go into a little bit later. So this is great that all these systems can track the patient's position, but how do they know what the ideal treatment position is for that patient? Well, they get all that information from your simulation scan. So these systems know the ideal treatment position because you send the external contour from the planning CT and the treatment isocenter location from your treatment planning system into the surface imaging system through the DICOM files. So they use this information to create a reference surface with which to gauge the patient's position in real time in the treatment room. So what happens once you turn the system on is they have the reference surface as dictated by the treatment plan and by the simulation CT scan. They can read the patient's surface in real time in the room through technology that we will go into in a little bit. These systems compare the two surfaces, and they give you 3 translations and 3 rotations. And these are the ones that tell you how different your patient's real-time surface is from what the reference is. And you can use all this information to gauge the beam and to gauge if the patient's position is currently satisfactory for treatment or not. So one little note that I wanted to make sure I told you guys about is that these systems not only use DICOM surfaces, you can also acquire a reference image with the cameras that are in the room. So this surface should only be acquired after you have verified the patient's position with internal imaging, because it will become your reference for positioning later on if you so choose. So you need to ensure that that position is accurate and that is not going to introduce systematic errors later on. The reasons why you might want to acquire a surface image capture with the surface imaging cameras in the room instead of using the DICOM surface is because it gives you a wider field of view. So it's not dictated by the range of the CT scan that you took at simulation. It's dictated by the field of view of the surface imaging cameras, which is wider. And it also takes out all those little differences that you might encounter between simulation and treatment. The patient is not going to set up exactly the same as he or she did at simulation. There will be slight differences, and the surface image capture in the room takes all those little differences out so that you can do intrafraction monitoring without that baseline delta embedded into it. Typically, it is the user's choice as to which reference they want to use. I just wanted to make you guys aware that you can use either one. So because surface imaging systems know what the ideal patient's position is, and they can track the patient's in-room position in real time, these systems can be used both for initial patient positioning and intrafraction monitoring. So these are the 2 general uses for this type of technology. The advantages of doing so with surface imaging is, one, they are using optical light, so it is non-ionizing radiation. So you are not giving the patient additional dose by monitoring them with this technology, which is great. 2, you are actually monitoring the patient's skin directly. You are not monitoring markers. You are not monitoring any sort of like surrogate fiducials for the patient. You are actually tracking the patient, him or herself. You can obviously get real-time information, which is great. And not only in a qualitative way by looking at the surfaces and seeing how the real-time one differs from the reference, but also in a quantitative way by using the deltas, the shifts that the systems give you in order to implement action levels depending on your experience at your facility. So let's talk about what the commercial systems that are available are currently. There are several systems out there, but the ones that I have listed are the most popular ones. Each system is different. They use different algorithms. They have different hardware, but they all in general quote sub-millimeter accuracy in surface positioning. So in this presentation, most of the pictures that you will see are from Align RT because that's what we use in my clinic. You will see a couple of pictures from Catalyst, from CRAD, just so that I can highlight some of the differences in the technology that the systems use. But in general, it'll be mostly Align RT. OSMS is basically Align RT, but sold by a variant. So everything that applies to Align RT applies to OSMS pretty much. But either way, all of the general concepts that we're going to go through apply to surface imaging as a whole. So it's not specific to any one vendor in particular. So let's talk about how surface imaging works. Again, the specifics vary depending on the vendors, but in general, they use triangulation and structured light to reconstruct the image. So top of the slide, you can see a couple of pictures depicting CRAD. At the bottom, you can see a line RT. So in the case of CRAD, they use a camera projector combination in a known geometry. So the projector casts a pattern onto the scene. The system knows what that pattern should look like, and it compares it to what the camera is reading. And because of that deformation, it can reconstruct the surface. For a line RT, it works slightly different. So in the case of a line RT, there are 2 cameras per pod and 1 projector, as you can see in the illustration. And so the projector casts a pattern, and the input from the 2 cameras is used to reconstruct the surface based on stereoscopic imaging. So I wasn't sure how familiar people were with stereoscopic imaging, so I thought I would put a little slide here illustrating the concept. So essentially, it's pretty much the same way that our eyes work. So both eyes are seeing the same image from a slightly different angle in 2D. Because the brain knows the geometry of one eye versus the other, it can take those 2D images and combine them into a 3D image with depth perception, thanks to triangulation. So essentially, you can think of the aligner T pods doing the exact same thing. They have the 2 cameras, which are kind of like the 2 eyes. The system knows the geometry of one versus the other, and thanks to the projector, it can pick out each pixel and figure out by triangulation where that pixel falls on the patient to reconstruct the surface. So what happens is the projector casts a pseudo-random speckle pattern onto the scene, and this pattern is such that every little area is different. So camera 1 and camera 2 can figure out that they're looking at the same area because the pattern for that specific pixel differs from the pattern from all the other ones. So they both can recognize that pixel and through triangulation figure out where that pixel is in space in order to create a point cloud of the patient's surface. So once the surface of the patient has been reconstructed, they obviously have to compare it to the reference in order to figure out how close it is to the position that it should be, right? So the way that image registration is done also depends on what system you're using. So Aligner T, which you can see here on the left, is using rigid registration, and it uses a user-defined region of interest, or ROI, to do that registration. So it only looks at that area of the surface. It does not look at anything that is not encompassed by that ROI. Catalyst, which you see on the other side, is using a non-rigid registration. So it calculates the shifts and rotations of the area around the isocenter, but then it independently shows the mismatch between the local regions that are further away from isocenter, and it casts a light on the patient to prompt therapists to reposition those areas in one way or another. So through image registration, the translational shifts in the AP, so anterior, posterior, SI, superior, inferior, and lateral directions are given by the systems, as are the rotational discrepancies. So from there, depending on the type of treatment that you have, depending on what your institutional preferences are, action levels can be set up to either further refine the position of the patient or to turn off the beam until the patient returns to a position that's deemed acceptable for treatment. So this is our first question. What do most commercial surface imaging systems use to read the patient's surface? The 3 options are structured visible light, infrared patterns, or heat maps.
Okay, great. So if you haven't joined one of our webinars before, go ahead to the polls section and make sure you weigh in on this question. We'll be going over the answer in just a moment. Looks like a lot of people have weighed in already, Laura.
Okay.
And it seems pretty split, the answer here.
Okay. So the answer is A, structured visible light. So as we were talking about earlier, all of these patterns are casting a light that you can actually see. So it's definitely visible. And it does have a pattern, but it is not infrared. And heat maps do not have anything to do with surface imaging at the moment. So we'll keep on going. So now we've discussed how the surfaces are read and how they're registered to the reference surface and how surface imaging systems give us all these differences between the two. But how do we actually know that the system is telling us the correct patient position in the room? How do we know that the system knows where the machine isocenter is so that the patient's position is absolute and it's correct in the absolute location of the treatment room? Well, through calibration and QA, like everything else in radiation oncology, these systems also have to be calibrated and they have to be QA. So the way that you tell the system where the machine isocenter is through this plate calibration. For aligner T in particular, I have not worked with the other systems, so I don't have experience, but I assume that they have a very similar procedure. For aligner T, they give you a plate calibration phantom, which is what you see in the picture. You set up the plate at isocenter based on your lasers or based on your crosshairs, depending on what you decide your procedure should be. And you just run the calibration algorithm, which essentially makes all of the cameras in all of the pods take pictures of this pattern so that they know their position relative to one another and they know where the position of isocenter is for the machine, as you indicated by setting up the plate calibration phantom. So this process tells the surface imaging system where the machine isocenter is based on lasers or crosshairs, depending on how you set up the plate. If you are doing treatments like SRS, you also want to make sure that your surface imaging system is calibrated to the radiation isocenter. You want to make sure that you're delivering the radiation where you think you are. So you need to make sure that you have a way of telling your surface imaging system what that radiation isocenter is. So the solution that VisionRT, the vendor of AlignRT, has come up with is they have this cube phantom that you can use for calibration. This cube phantom has radio opaque markers embedded in it. So what you do is you set up the cube phantom based on your surface imaging input, and then you run a Winston-Lutz test. The system analyzes those images and it can tell where the MV isocenter is with respect to the surface imaging isocenter and correct them accordingly. So those are the two calibration aspects of it. What you should do anytime you get a new positioning system, anything that's new in general, is very useful to perform an end-to-end test, and surface imaging is no different. So what you do in an end-to-end test is you take your phantom and you essentially treat it like you would a patient. So you set it up at simulation like you would set up your patient, you scan them the same way, take them into the treatment planning system, place the isocenter, set them up at the machine, and treat them exactly like you would your patient. So in this case, in order to assess how accurately surface imaging was positioning our phantom, what we did is we positioned it based on surface imaging, and then we took KV OBIs, so an orthogonal pair of radiographs, and then we took a cone beam CT, and we compared the position of all these things with what surface imaging was giving us. In our case, our results were within 1.5 millimeters, which was acceptable for our purposes. This was with a phantom that was in slabs, so it was kind of hard to position. So there's like a bunch of different factors that play into that 1.5 millimeters. But in general, we were happy with it because of our tolerances. We are not using this system for SRS, but we are using it for initial patient positioning of SBRT and interfraction monitoring. So we've talked about how the system works and how to ensure that the information they're giving us is trustworthy, so we can start talking about their actual clinical uses. So in general, we talked about how you can use them for initial patient positioning and interfraction monitoring. So let's talk a little bit more about that. When you don't have surface imaging in your center, Typically, how the patients get positioned is based on skin marks and lasers to perform the initial alignment. So the therapist will try to take out all the rotations the best they can with 3 to 5 skin marks, 1 to 3 usually along the supinf direction, and then 2 lateral marks, 1 on each side. Once they've aligned the patient to the skin marks, if there's any shift that needs to be applied in order to take it from the marked isocenter to the treatment isocenter, then they apply it. If not, then they go on to the imaging portion. Surface imaging systems can substitute this process by giving therapists the equivalent of thousands of skin marks, essentially, to gauge the position of the patient. So how accurate the position that the surface imaging system is giving you with respect to the treatment position is going to be dictated by where your target is. And we'll talk more about that later and how well it correlates with the surface. But essentially, you run into the same issue with lasers and skin marks when you position the patient. They don't always correlate to the treatment position, and they are a lot harder to use for alignment because it's a lot more limited information. On top of that, if you're using surface imaging, you have the added safety feature that you no longer have to, the therapist no longer have to mentally apply the shift from the marked ISO to the treatment ISO and manually move the couch. The surface, the reference surface for the surface imaging system is automatically placed at what should be the treatment ISO center. So that's one step that gets bypassed, and it minimizes potential errors and extended treatment time. So for interfraction monitoring, since these systems use non-ionizing radiation, the patient can be monitored throughout the treatment without any detrimental side effects. So these systems can be interfaced with the treatment machines. If a detected position is out of tolerance based on whatever preset threshold your institution has set, the beam turns off. So this same function can be used during gated treatments or during deep inspiration breath hold treatment, which we will talk about that later. And it becomes a really easy tool to implement in those types of treatments because the patient gets to do voluntary breath hold and you get to monitor the breath hold throughout the whole process. So since we're talking about the clinical uses and we've been talking about very general approaches to that, I thought it would be useful to go into some factors to consider when using surface imaging in the clinic. So what should we take into account? We mentioned earlier that surface imaging systems register the real-time surface to the reference, and that's how they determine the difference between the two. So if it doesn't have any salient features to drive the registration to a unique solution, it'll be really hard for the system to obtain reliable results. So that is something that you really have to keep in mind, especially when you are drawing your region of interest on the patient. So if you picture 2 cylinders and you picture trying to figure out the exact position of where one should be with respect to the other, if you are just looking at one little ring around the cylinder, it's going to be really hard for you to figure out how you should match them if there is no feature that is driving that registration along the long axis of the cylinder. Everything is going to look the same. So you can run into the same issues with patients if they don't have anything on their surface that tells the system where they are in the supinf position. So that's something that you really have to keep in mind. Another thing to take into account is non-stable anatomy. So if you have a patient with a lot of fatty tissue, if you have a patient with a lot of loose skin, that tissue is not going to fall in the same place every single time. So if you're treating something that's very superficial and that it moves with the skin, that it correlates with the surface really well, then it's not an issue. But if you're trying to use surface imaging to align a patient whose target is very deep and they have a lot of loose tissue, the position that the surface imaging system is going to give you may not be completely correlated with what the actual treatment position is going to be once you do internal imaging. So that's something to keep in mind. But again, you can have the same exact issue if you use lasers and skin marks. So it's nothing new. It's just another piece of technology, and like any other piece of technology, it has its limitations. So you need to know how to use it properly. So take-home point is salient topographical features improve performance of surface imaging systems. So remember that. Another thing to consider is the location of the target, and we briefly alluded to that just now, but you need to really think about whether the surface is a good surrogate for target position. So if the target position correlates well with the surface imaging will obviously give you a great starting point for the initial position of the patient. Otherwise, the internal imaging is going to show that the target is not aligned. So this is something that you also have to keep in mind when you're using this tool for interfraction monitoring, because the surface will not show internal motion necessarily, right? If there's digestion going on, if there's bladder filling, the surface, the external surface, is not necessarily going to show any of that motion. If your target position is affected by that internal organ motion, then even though your patient is not physically moving externally, the target might be misaligned. So when you do interfraction monitoring with surface imaging systems, you need to realize that you are monitoring just the external motion, that it does not guarantee for targets that are subjected to internal organ motion, it does not guarantee that that target is staying where you think it is. So this brings us to our next question, which is true or false, region of interest selection does not affect the shifts calculated by surface imaging systems.
Okay, we're going to give everyone just a moment to answer this question. And also encourage everyone to use the chat to go ahead and ask Dr. Laura Padilla any questions that you might have about the topic. All right, it looks like everyone is weighed in.
Everybody answered?
I think so.
All right. So the answer is false. So region of interest does affect the shifts calculated by the surface imaging systems. And this goes back to what we were just discussing about making sure that you have salient topographical features in your region of interest. Otherwise, the registration algorithm might not give you the most reliable results. So I told you guys at the beginning of the presentation that I was going to talk about a couple of specific clinical applications that are common right now in the clinic for surface imaging. And the ones that I want to go over with are deep inspiration breath hold treatments for left-sided breast patients and surface image-guided stereotactic radiosurgery. So in both cases, the target that you're treating correlates well with the external surface, right? So this is a big reason why surface imaging is so prevalent in these two treatments. So why do we do deep inspiration breath hold treatments to begin with? I don't know how familiar you guys are with these types of treatments, but essentially what we're trying to do is we're trying to make sure that we protect the heart of the patient as much as possible. So one way to do that is to ask the patient to take a deep breath in during treatment. So when the patients take a deep breath in, for a lot of them, not for everybody, but for a lot of them, when their lungs inflate, the heart goes back and down. So it gets further away from the chest wall. So it gives extra space to the planner to put that radiation in while still avoiding the heart. So if you're using surface imaging, you can ask the patient to take a breath hold voluntarily instead of using other devices like ABC, the active breathing coordinator, which forces the patient into breath hold by closing the breathing tube. So this approach is a little bit more patient friendly, but you just need to make sure that your patient can actually do it. So Again, if your surface imaging system is interfaced with your treatment machine, then automatic beam hold is possible. If not, you can do it manually, and that's okay. And in order to make it easier on the patient to hit that breath hold level every time, their vendors provide visual guidance devices where the patient can actually see how they're breathing and where they need to get in order to be within the correct breath hold position for treatment. So there's a lot of literature out there on the use of surface imaging in DIBH and just on the benefits of DIBH in general. But I wanted to just look at a couple of articles to give you guys a taste. So the first one is by a group in the Netherlands. It was published in 2013 in the Red Journal, and they looked at 20 patients that they treated with DIBH. They used cone beam CT for setup verification, and they compared and they also acquired 3D surfaces with Aligner T, and they compared the setup of cone beam CT versus Aligner T to figure out what the differences would have been from one versus the other, cone beam CT being the baseline. And they found that between the two, there was a systematic error in all directions, so vert long lat that was less than 1.7 millimeters, and random errors of less than 1.5 millimeters. So the system proved to be a useful tool for these types of treatments. Another study that also looked into the use of Aligner T in particular, so surface imaging for the IBH, was this study published in the Red Journal again, but this one is really recent. It's from 2017, and it's from a group in North Carolina. And they looked at 20 patients treated with DIBH using Aligner T. They took a pre-radiotherapy SPECT scan and a 6-month post-radiotherapy SPECT scan in order to gauge if any cardiac abnormalities arose due to treatment. And they actually recorded no perfusion or wall motion abnormalities in any of the treatments. So this is saying that the use of surface imaging to guide the IBH is actually safe and reliable. So I wanted to show you what an example workflow in the clinic would look like for using surface imaging for the IBH. This is just an example. Every clinic is likely to do it differently, but in general, what people do is they take two surfaces. So they will take two scans, one CT scan in free breathing and one CT scan under breath hold. They will send the free breathing surface and the DIBH surface to the surface imaging system. So they will position the patient in free breathing, and that just because it's a lot more convenient for the patient, it's a lot more convenient for everybody to be able to position the patient while the patient is breathing normally. Then they will switch to the DIBH surface and they will check the breath hold reproducibility with that surface. So in theory, if the patient is taking a deep breath in the same way every time, if you set them up to the free breathing surface, they should automatically match their DIBH surface once they go into breath hold. So that's the train of thought behind that. So after they verified the breath hold with the DIBH surface, they go into internal imaging for verification. And again, what that means depends on the institution. It could just be port images. It could be a cone beam CT. And during treatment, the patient will be treated and monitored using the DIBH surface because that is the actual treatment position. Now, whether that institution decides to take a reference surface capture with the cameras in the room or not, that is different, but in general, they will all use the DIBH surface for treatment because that is the treatment position. So talking about stereotactic radiosurgery a little bit, obviously it's a treatment that delivers a really high dose to the patient in one fraction. And you really need to make sure that you are keeping track of what the patient is doing during treatment because you want to ensure that that patient is not moving so that the radiation is going to the place that you want it to go and nowhere else. So it is convenient to use surface imaging for this purpose because by monitoring the patient's face and making sure that that is steady, you can feel a lot better about the fact that your target is in the correct treatment position. So one thing that is very important to keep in mind when using surface imaging for SRS is the fact that you need an open mask. So we've been talking about how surface imaging monitors the patient's skin, and that is absolutely true if the skin is uncovered. So if you put a mask in there, the surface is just gonna monitor the mask, and that's not gonna do you any good. So you need an open mask that's gonna leave the patient's eyes and eyebrows and nose and a little bit under, and pretty much from side to side, from hairline to hairline open, so that the surface imaging system can track it. So because you're using an open mask, you need to make sure that you're careful with your patient selection. Those open masks, the patients can move in them if they really try. So you don't want to put a patient on the table with an open mask that you know is going to be non-compliant and it's going to move all over the place. So that point aside, the first thing that you do is you position the patient with surface imaging, and then you always verify the internal positioning of the target with the cone beam CT. And then once you've done that, you can monitor the patient with surface imaging and do positional corrections with the system if that's what your institution decides to do. So there are several articles out there that have investigated the use of surface imaging in a frameless SRS setting, and a lot of them are from UCSD, but they all show that essentially you achieve equivalent outcomes to framed and other frameless techniques when using surface imaging with open masks for SRS, with the added benefit that you have increased patient comfort. So I want to show you an example workflow for SRS with surface imaging. So you would initially position the patient with surface imaging based on the DICOM surface from the treatment planning system. Then you would do the cone beam CT for internal anatomy alignment. Then you would acquire a reference surface. For SRS, most of the time they acquire a reference surface with the cameras in the room because it's very important to detect very, very small shifts when you're doing interfraction monitoring. And so you don't want any little differences between the sim and the treatment positions to interfere with your ability to detect these really small interfraction motions. So you acquire a reference surface and then you start monitoring. And then from there, throughout the treatment, you can reposition with SI if that is with surface imaging, if that is your institution's procedure. Some people will rotate the couch back to 0 if they are off of 0 and take another cone beam CT. So that depends on the institutional preference. So this brings us to our third question, which is true or false. The position determined by the surface imaging system always matches the treatment position determined using internal imaging.
All right, this is our last question, so go ahead and weigh in. And also I want to encourage anyone who hasn't asked Laura a question in the chat to go ahead and make sure we have some questions for our Q&A session. So feel free to enter them there in the chat room so we can go over them. I believe this is the last section. Is that right, Laura?
Yeah, we have essentially one more section and then the conclusions.
Okay, so everyone looks like has weighed in on this question. It seems like everyone's getting it correct.
Excellent. So that is false. As we have talked extensively, and we will talk about some more, just because your surface matches with the sim surface, it does not mean that your target is necessarily internally in the same place. So I think we have seen a pretty thorough overview of surface imaging so far, and I just really wanted to emphasize some of the limitations, because it's very important when you use a new technology that you not only know what it can do, but also what it cannot do, so that you use it properly. So for initial positioning, again, the external surface does not necessarily correlate with the position of the target. So these systems were never meant to replace internal imaging. They are more a tool to replace lasers and skin marks than they are to replace internal imaging. So you need to be very mindful of where your target is and how sensitive it is to internal organ motion. Also, remember that you are tracking the patient's external surface with these systems. So if the patient loses weight or gains weight or they're swelling, your position is going to be different if you base it on the surface imaging. So this is kind of a double-edged sword. So if your patient swells up and you are aligning to the surface, your treatment position is not going to be correct, right? Because your surface is in a different place with relationship to your target from what it was during the planning CT at simulation. On the other hand, this system is telling you that there's something that has changed with your patient. So that's really useful information. It might lead you to try to investigate further, figure out if you need to replan, figure out if there's something that's going on with the patient that you're not aware of. So just because the external surface is not taking you to the treatment position as closely as you would want it to, it doesn't mean that the information that it's giving you is not useful in other ways. So also keep that in mind. ROI selection, we have touched upon that already, especially with the question, but just make sure that whatever you select in the ROI has useful information for the system in order for it to do the match. So if you choose an area that is flat, the system will not have enough information to properly calculate rotations or translations. So also keep in mind that if you select an ROI that is too large or too small, or it doesn't encompass the area of interest for treatment, the shifts that it gives you might not be adequate for the position that you're trying to achieve. So one thing that we haven't really talked about all that much, or actually two things that we haven't really talked about all that much, but that are also important, is the fact that surface imaging systems, they read the surface and they don't know what surface they're reading. So it's not like they know to read only the patient's skin as a surface. They will read anything that is in the field of view within that ROI. So if you have sheets, if you have clothes, if you have a mask in the ROI, the system is not going to know how to differentiate it, or at least not at the current level. So it will think that that's the patient's skin, and it will try to calculate the match with respect to the reference surface based on that. So the sheets, clothes, masks will interfere in the correct positioning of the patient. And shadowing. If you have really bulky immobilization devices and they cast a shadow on that speckled pattern that the system is using to construct the surface, you will have spots that the system will not be able to see. So also keep that in mind. For patient monitoring, things like breathing versus voluntary motion. So if you have a target that it's in the abdomen and you have your belly in the ROI that you're tracking and the patient is a very heavy belly breather, you can take out the belly out of the ROI, but it might still, the breathing pattern might still cause problems with your shifts. It might still make your shifts look larger than what they actually are. So if you have your system interface to your machine and it stops the beam every time the shifts are larger than a certain amount, you might have to make those thresholds larger. At that point, you are opening yourself up for there to be voluntary motion that goes unnoticed. So it's something that you have to keep in mind. Also, again, remember that these systems are tracking the external surface. They know nothing about the internal motion unless that gets reflected on the external surface. So just because it looks like the patient is nice and steady on the table does not mean that your target is in the same place as it was when you did the internal imaging. So keep that in mind as well. And finally, the surface occlusion by the treatment machine. So these systems only read whatever the pattern sees. So if you have the gantry and projector in the way of that pattern and it shadows that pattern on the patient, that's going to be a dead area of data. The system will not know what's going on with that area of the surface. So that can cause either the system to not be able to give you any sort of shifts because it doesn't have enough surface to do the matching, or to give you shifts that are not accurate. So that's something that you also need to keep in mind if you're using systems like this for interfraction monitoring, especially if they are interfaced with your machine. So one of the biggest challenges right now with all the surface imaging systems is the fact that it's hard to implement something when you don't have any recommendations to go by. So there is an upcoming TG report that we're working on. It's TG 302. This report is set out to review the current status of surface imaging. It will provide recommendations for commissioning, for QA, for clinical workflows, for how to do the risk assessment on using these systems. And it will also discuss the limitations and pitfalls, which we have gone over in this presentation. It will also present emerging clinical applications for surface imaging, which we did not go over on this presentation, but hopefully next time. So to conclude the presentation, I just wanted to just touch on some highlight points. One, surface imaging is a really useful tool for initial patient setup and interfraction monitoring because it's markerless, so you're actually tracking the patient, not some surrogate for the patient. It uses non-ionizing radiation, so it does not increase the dose to the patient, so there's no added risk, and it gives you real-time quantitative feedback. However, make sure that you're aware of its limitations. It was never meant to completely replace internal imaging. So especially if your target does not correlate with the surface, you want to make sure you do internal imaging to ensure that the patient is treated in the correct position. You are tracking external surface, you are not tracking internal motion. So just because the interfraction monitoring is showing the patient is not moving does not mean that internally the intestines or the bladder or whatever else is not moving. And also be aware of camera occlusions and what they do to your shifts. And be on the lookout for TG302. It will hopefully provide a lot of useful information for users of surface imaging. And that concludes my presentation. I'll be happy to answer any questions you may have at this time.
Thank you so much for presenting that webinar, Laura. We can head over to the chat. Our first question is from Luis. He asks, what is your daily, monthly, and annual QA?
So right now, what I'm doing for QA for surface imaging is I am doing the plate calibration that you saw whenever okay, so let me back up. For daily QA, they use that plate calibration and the therapist set it up on the table and they just run an algorithm check. So the system does not get recalibrated on a daily basis. It just checks to make sure that essentially the cameras haven't moved in their position and that the isocenter is where they thought it was. So they keep track of what the differences of this daily QA are. And I keep an eye on the trend. If the trend starts deviating and it starts getting above 0.5 millimeters RMS, then I will recalibrate the system to make sure that we are as accurate as possible. We do not have any annual QA procedures right now. Again, we don't use the system for SRS. If we did use it for SRS, the QA would be a lot more extensive because I would want to make sure that the SI isocenter, so the surface imaging isocenter and the MB isocenter were really close. But since we're not using it for that purpose, our QA is not as extensive. So we don't really have an annual QA procedure that we're doing right now.
Okay, thank you for answering that. Our next question is from Dustin. What are some of the primary commissioning tests and routine QA tests that would be employed for these systems?
So for primary commissioning tests, again, end-to-end test is really something that you should do for it. You should make sure that your surface imaging system is telling you a position that coincides with your KV and cone beam CT systems as well, right? So just like we discussed for the end-to-end test, you grab a phantom that represents your patient and you treat it exactly like you would your patient. You set it up, you take internal images with the KVs, with the cone beam CT, and you compare that information to what your surface imaging system is giving you. So that is the commissioning process, aside from whatever test the vendor does when they install the system. There is no set guideline right now as to how to do the commissioning for it. There's a lot of different approaches out in the field currently. the approach I took was to do end-to-end testing, and that really gave me an idea of how I could use the system and what the limitations were. And I suggest you do the same. As far as annual QA, again, it depends on what you're using your system for. There are currently no recommendations for it. That's what we're working on. But if you're using your system for SRS, you absolutely need to make sure that you check the coincidence of the systems isocenter with the MV isocenter on a regular basis, especially if you're going to use your system to reposition the patient in between treatment beams.
Okay, our next question is also from Dustin. From a practical standpoint, what are the primary barriers for doctors and therapists to implementing a surface imaging program?
So in my experience, what I have found is that a lot of the issues are more cultural. People like doing what they're used to doing, what they have been doing for a long time. And so a lot of the hurdles that I had to, overcome were basically just getting people to buy into the system, to make sure that they knew that there's a learning curve and that you might not know exactly how to use it at the beginning, but if that you learn how to use it properly, it gets easier and it ends up being a lot faster in the long run. And it gives you a lot more information than just using lasers and skin marks. So I would say the cultural aspect of the department is probably what the biggest obstacle was, to be honest.
Thank you for answering that. Our next question is from Stephen. When is TG302 supposed to be published?
I think our deadline is a year and a half from now. So okay. Within 2 years for sure, I think.
Great. Our last question is from Robin. What other indications does your clinic use SGRT for?
So we started using it for SBRT, and that was just a matter of how our clinic was organized and where our surface imaging system was installed in one machine. So we started with SBRT. We could have started with any other side, but the way that we were set up, SBRT is what made the most sense. Plus, we have physics present during SBRT treatment, so there was a lot more people to help overcome whatever issues might arise when you're first implementing a clinical system. So after they all got used to SBRT, doctors actually started requesting surface imaging for difficult setups. So without physics prompting it or anything like that, they realized that it actually helps with rotations, especially a lot, because the therapists get a lot more information on how to tweak the patient's rotations. So they have been using it now increasingly for breasts. So whereas we really weren't using breast, we really weren't using the machine that the surface imaging system is on. We weren't using it for breast treatments before. Some of the breast patients have started moving towards this machine just because we have the surface imaging capabilities, and it has proved to be really useful for setup. And we have also used it for really long treatment fields where rotations are really hard to take out unless you have the surface imaging system helping you. So fields that are really long that would require like an upper OBI and a lower OBI, and it would require like us shifting the panel in order to see the full extent of the field. Those types of treatments are now being done on the machine that has surface imaging so that they can set them up a lot more easily with surface imaging, and they don't have to image as much and they don't have to take as much time in the setup process.
Thank you so much for answering those questions, Laura, and for presenting this webinar.
My pleasure.
And thank you all for joining for this free event hosted by WePassed. If you'd like to review this webinar, it'll be available for a limited time on the WePassed website. And for this and other recorded webinars, are always available on WePassed.com for subscribers 24 hours a day, 7 days a week. So be sure to register through wepass.com to become a subscriber to see our whole library of webinars. And for up-to-date information about upcoming webinars, be sure to follow WePass on Facebook and Twitter. And thanks again, and have a great night.